really delighted to introduce John Samet, who's the Dean of the School of Public Health, and he will give a brief introduction and discuss how does public health reduce health disparities. Thank you, John, for being here.
Good morning. Buenos dias a todos. Bienvenidos. Happy to be here with you today. And welcome to this conference. The attendance is terrific. Let me ask who's here. How many of you are students? Faculty? From the community? Chancellors? Otherwise, others? Great. Well, okay. Welcome and glad to see everyone here. Actually, when I put together this title, we could actually just stop with this and go around the room and ask everybody to answer the question. I know if I turned to Fernando and said, what's the answer to the question, you would say? LRPC. The LRPC. Okay, I'll stop playing that game. But this is beyond the 21st anniversary of the LRPC. We are at the 10th anniversary of the School of Public Health, the 10th anniversary of the Colorado Public Health Act, sort of important synergies there. So it is an important time and a critical issue. I will say, I started my academic career at the University of New Mexico in 1978. The first study I did was on smoking in the population of Bernalillo County, New Mexico. At the time, there were essentially no data, very scant data on smoking among the Hispanic population, and already this anomaly of low lung cancer rates in the Hispanic males of New Mexico. And over the 16 years I was there, much of my work was focused on topics that remain current today. Now, I want to start by talking about the origins of health disparities, because we can't talk about reducing them without thinking about where they came from. And remember, Fernando showed these nice graphs with arrows going from evidence to policy. If only the world worked that way. But it doesn't, as we all know. But again, in thinking about research and how we're going to address health disparities, we have to think about their origins. And I'm going to show you sort of 4 different models, potentially overlapping, potentially all holding. And I'm showing you these because when we think about doing research or policy, we need to think about what are the pressure points. Where is it within these models of how disparities are produced? That what we do as a school, as a health campus, could make a difference. So one, shown here, this idea of genes, that there are genes that differ across populations that may drive population health risk. Okay, sometimes true and probably less true than we ever would have anticipated as we set out on understanding the human genome. So there's the genetic model. Now, here is one with also important, and again highlighted in some of the data that Fernando showed us, unequal distribution of resources, different environments, different access to health care, with effects on those sort of more proximal mechanisms, those that get at us, that affect our health status. Okay, and called by Ana Diaz the fundamental cause model, looking back up to sort of this root cause change. This one, sort of a pathways model. Here, the idea that who we are by race, ethnicity, socioeconomic position, figures into a number of factors: access to healthcare resource, the nature of our environments, what we're exposed to, our psychosocial environments, and again, influencing health in the tremendous body of work pursuing this model. And then last, the idea that genes and environment somehow come together. Again, much work. There are people on this campus who have done work oriented towards this model. But within these different constructs, and here they all are, the evidence that we might generate by doing research figures into different points. And our problem is multi-level. It's stretches from the top to global factors down to who we are, our environments and our genes. The one example I always use now to talk about how things happen globally is tobacco. Okay, so how many tobacco companies are there in the United States right now, majors? We're down to 2. Okay, if you look globally, the tobacco market is mostly 5 companies, with China National Tobacco at the top as the biggest. So, you know, again, we go from global down to us as individuals. And there are many different representations of these kinds of things, but I want to dwell on this upstream, downstream idea, because when we think about what might be changed because we have some new evidence, sometimes it's upstream and sometimes it's downstream. And we'll come back to some of the problems associated with this thinking. So if we go after root causes, if we go way back upstream, there's some real challenges that aren't there, because then we get into our political systems, our economic systems, and what might be amenable to change, or how these forces are moving away from, in fact, reducing health disparities to, in fact, increasing them. So challenges here in what we do. So schools of public health and health inequities. I put up the mission of the Colorado School of Public Health. And I put this up because if you go to the website, this is what you will find. And when I looked at it, I immediately began to rewrite it in my head. And you see diverse populations at the end. You won't see health equity ingrained within the mission, but that's what it says. And we certainly have the goal of promoting physical, mental, social, and environmental health of people and communities in the Rocky Mountain region and beyond. And you can't do that without thinking about the diversity of populations and the disparities of health and disease across them. So what do schools of public health do? We train. Certificate is an example. We do scholarship. We look at policies and what might be done. We evaluate the consequences of policies. We do, I'll say, evidence-informed advocacy. Okay, and I think that's a very important role for faculty, students, staff, and the partners of a school of public health. And when we look at where health disparities come from, going back to our models, going from the top, social, political, economic drivers down to the bottom to us, our research stretches across that span. Our efforts to evaluate stretch across that span. So our reach can be potentially very broad, and I think we have to keep that in mind. It's sometimes harder as you go more and more upstream to say, well, how do we have impact? Is it organizing communities to take action with their political leaders driven by the evidence of what is happening in their communities, and how what happens in Washington, for example, may figure in. So we reach across this spectrum. I want to dwell for a moment on research. This is from a series of articles in The Lancet about 3 or 4 years ago that were useful. They talked about how to make research more meaningful. And there's this little figure here about research. And on the x-axis is relevance to application, and on the y-axis is advancing knowledge. Okay, so we do scholarship. We want to advance knowledge. It's part of what we teach. It's part of what we train. It's ingrained in us. Where we don't want to be, notice that waste quadrant where whatever you do is neither applicable nor advancing knowledge. Sad piece of fact for you. What is the median citation frequency for a published paper? Is it 10? Is it 100? 5? 2? 0. Somebody got it right. So somebody got it right. So what does that say? So the millions of papers coming out, many, many, many are in that bottom quadrant. I suspect many of us have been in academia for a long time, have our contributions down there. But I think where we are in public health is what is called the Dahl quadrant, applicable and advancing knowledge with application. Richard Dahl, leading epidemiologist for 60 years, pioneer in doing work on smoking. So it's named after Richard, Sir Richard, in terms of his contribution. So that's where a lot of our scholarship sits. Now, if we turn to health disparities, we're doing a lot. We have many, many, many papers. So this is just a crude publication, PubMed search, using epidemiology and health disparities. Remember, 2017 is not yet complete, but we're going to be over 3,000 papers. Okay, 3,000 papers. So we're generating a lot of scholarship on the question. A little more of this. Health equity. Okay, using that as a search term. There's got to be some overlap between these, but I just want to impress you that we're not lacking in papers. Okay. Health inequity. Lots more. Okay, and health disparities. Big numbers. Okay, so we're not lacking in papers, and hopefully many of those papers sit in that Dahl quadrant, and they are useful and applicable. I'm just going to show you a few. I sort of went through some papers by faculty that relate to this. I'm just going to show you little bits from conclusions. Multivariate models, barriers to access were most likely for youth with low family income and those without public health insurance. Anybody surprised? No. Okay. Changing trends in the prevalence and disparities of obesity and other cardiovascular disease risk factors using NHANES. Need for better prevention, particularly non-Hispanic white group that exhibits the worst trends. And of course, if you look at the maps, we know what's happening in Appalachia and parts of the South. Everything is going in the wrong direction, including lifespan. A little bit more. Here's a genetic study. And again, here talking about the fact that things don't vary so much across populations. Still some very interesting things to understand about why the risks of obesity, diabetes, and some other problems are so common among the Hispanic Latino populations, as Fernando already highlighted. Racial disparities in health status, papers on American Indians, Alaska Natives, and again, data continuing to show the same thing, and I think that's the point I want to make. So we have lots of evidence and ammunition to move forward. So evidence is not absent. Evidence is not absent. People talk about the absence of evidence. We hear the evidence is not absent. And so why aren't we moving forward faster in addressing these issues? So some of it, I think, lies in the pathways to translation. So Fernando showed, and many of us write these nice diagrams where we do research, we do something, we publish a paper, and something happens. Does the world work that way? No. So, you know, of course the answer is not, all right? And it's far more complicated what actually happens. I spent 14 years as chair of epidemiology at Johns Hopkins. We graduated an awful lot of students with doctoral degrees in epidemiology, and I became known for my last question, which I always ask the last question at presentation of ideas, and said, well, what difference is your paper going to make? What difference is your research going to make? This became known as the Dr. Samet question. I lost my punch, and at the end they said, oh, I'm ready for you. Here's the Dr. Samet question to answer. But it's never simple. And I was just wanted everybody to think about that, because scholarship itself is not the goal, but doing something with the scholarship is. So when we think about how things work in the real world, we generate evidence, and there are gaps in the evidence, there's uncertainties, and sometimes those uncertainties are sufficiently pressing that we don't take action. Sometimes we manufacture uncertainty. Think climate change, for example, or tobacco. But then other things play in, and politics, costs, advocacy, activists, who has the biggest stake, the biggest voice, the most power, all these things figure in, and you know where the balance ends up is sometimes complicated. I put this little figure together a few years ago, but it'll make the point, okay, that looking upstream and looking to Washington, there's an awful lot at play, okay? Look at the new tax bill and think about its implications for disparities, for example, okay? And so while there may have been scholarly analyses pointing to the implications in the new tax bill for income distribution in the country, that I don't think was high on the minds of those in Congress, or many of those in Congress, as the bill was passed. So I want to turn just as a quick example to the environment, where we live, what we're exposed to, and what happens as a result. And again, here's one of those figures, one of those diagrams that's sort of holistic about who we are and where we live affects what we're exposed to and the environment around it. I just came here after 9 years in LA. Who lives nearer freeways in LA? Those with more income or those with less income? I think you all know the answer. You know, and LA as a very interesting place, truly a non-majority population place, Hispanic Latinos are far more likely to be adjacent to some of the busier freeways, all mapped out. So there are studies like this one, which looks at the national level, who has more exposure to sources of airborne particles. This is a recent article from the American Journal of Public Health. I'm only using it as an example, but here's a cumulative frequency plot. And if you look to who has greater exposure, not surprisingly, it's those who are within minority groups and those with less money, greater exposure to sources of particulate matter. And here's a little bit more of the same, but we'll skip it. You might think here locally, for example, about the I-70 project and who lives adjacent to I-70 and what the implications are for some of the communities adjacent to that. You might think about how could a school of public health be useful in that kind of important discussion as part of the city is re-engineered. So will new tools help? So I'm just going to list a few things. So big data, I guess you can't give a talk these days without saying big data. Might also ask anybody what big data is, but it's certainly been in the news lately, hasn't it? Who did get one of those Facebook letters that your data had been used? Anybody? Not admitting it? I don't know. Okay. But are there hopes? I'm going to show you, in fact, later in the day we'll hear from Eliseo Perez Estable, and his institute actually did a workshop on big data and its potential to be useful in identifying issues that might be addressed around minority communities, and I'll come back to that. So-called omics techniques, ways to understand genes and exposures, for example, may be useful. Citizen science, giving the tools to communities to look at their food, their exposures. We have many now emerging technologies, for example, for assessing exposure to air pollution. Devices that don't cost so much, that can be worn by people in communities and generate data. I think speaking to Fernando's, the product of the LRPC, community-empowered engaged research, perhaps facilitated by the School of Public Health. Crowdsourcing, just as another example of data. I heard a fascinating talk a couple of weeks ago by Steve Friend out at the University of Washington. He has a new venture that is essentially crowdsourcing research, bringing in people in large numbers, providing tools, using the iPhone or the telephone, smartphones, to generate data that might be useful. So wouldn't there be power in joining data from many communities together to explore some of the issues that we're talking about today. So here's that description of the big data opportunity, and a number of opportunities set out along with a number of challenges. And I'm not going to put these, spend any time on the details here, but this paper is published. So what do we need? More research or more action? So I sure do have a lot of research, and the research funding has been available. I think we've done a terrific job of showing over and over again that it's not good in many ways to be in a minority community or to have less social capital, fewer resources, to undergo discrimination, to not have best education available. We could go down the list. So how do we get to more action? And I think that's the question we really need to think about. I think a question that's before us, before the LRPC, before the School of Public Health, before all of us. So I think as we go through the day today, we should be thinking about how to better affect all those places from which arrows go to poor health and health disparities, and what can be done about it. Thank you.